in this presentation. The main objective of this presentation is to share experience on skin entities and to identify the challenges and opportunities that we can use to solve the problems of patients affected with these skin entities. Based on our experience at the Mycetoma Research Center, a WHO Collaborating Center on Mycetoma. I'm going to talk about the skin entities, the challenges, the opportunities, and will share with you some of the take-home messages. And this is the outline of my presentation. For those who may not be able to stay till the end of this presentation, I am going to conclude by saying that skin entities are a scar in the human conscience, and our job is to heal it, as they are non-glorious diseases. Ladies and gentlemen, skin entities are caused by a variety of bacterial, parasitic, or fungal causative organisms. The bacterial causes can cause Bururi ulcer, leprosy, yaws, and scabies. The parasitic causative organisms can induce cutaneous leishmaniasis, post-Kala-Zardermal leishmaniasis, lymphatic filariasis, onchocerciasis, and ectoparasitosis. For the fungal causative organisms that can cause skin entities, the famous example is the mycetoma and the other deep mycosis. Skin entities has a similar geographical distribution, similar epidemiological characteristics, and similar social impact. They account for around 10% of all skin entities. They present with a visible skin changes and alteration, occur in the same setting, and have the same manifestations. They prevail in setting characterized by fragile health system. They lead to psychosocial problems, stigma, exclusion, and disturbances, and psychological changes. Early case detection and management strategies can be integrated to optimize the use of the available resources. The challenges and opportunities, weakness and strengths, and threats. These are the important issues I would like to discuss in the coming few minutes. There are many threats, many challenges facing clinicians dealing with patients with skin entities. Access to remote communities where these diseases are endemic, scarcity of resources, lack of capacity, tools and diagnostic deficiencies. These are the important challenges facing us in dealing with these patients. These skin entities will induce stigma, long-term disability, mental health condition, and community exclusion. Again, weak surveillance system. Cost of this surveillance system, and the cost of the treatment are important challenges facing clinicians dealing with these patients. The opportunities are many, and we should grab these opportunities to improve the quality of life of patients affected with skin entities. WHO advocate an integrated approach to skin entities to enhance early detection, treatment, morbidity management, and disability prevention. The integrated approach will save resources, effort, time, and for better care of the affected patients. No doubt, community health workers have a major role in delivering primary health care. An intervention at that setting, and that was clearly demonstrated by the different campaigns conducted in endemic areas. We need to have early case management, care, rehab at the primary and the secondary health care levels. Technology now is mushrooming, and it can be used to detect and to diagnose skin entities at an early stage where the outcome will be more favorable. Various technological devices, including smartphones, mobile, can be used either online or offline, even in rural areas, to collect data for early case detection and management of patients. One of the good news, now the WHO has invented an applications on skin entities diagnosis, and that can be very helpful in the early case detection and management of these patients. Again, WHO has established diagnostic technical advisory group with skin entities subgroup for improvement of the quality of diagnostic tool for these diseases. Artificial intelligence now is used as a tool to support the diagnosis and the management of these skin entities. And the teledermatology is a good example of that. Ladies and gentlemen, the take-home messages that we need to adopt holistic, community-oriented and cross-cutting approaches to address comprehensively skin entities and other skin entities as part of the universal health coverage and leave no one behind. Again, holistic and integrated approaches in tackling skin entities, physical, mental suffering and distress is badly needed. Integration in almost all its aspects, including diagnostic, technology, capacity building, is vital. We need to have a very clear, objective, integrated management approaches. We need to spend more money on research, on prevention, and on clinical care for these patients worldwide. Again, the WHO has published the Skin Entities Framework to guide countries and partners in implementing integrated public health interventions. Again, further, it published a roadmap to help people to work on that and to accelerate the progress towards 2030 NTD's roadmap targets. NTDs need to be recognized in the global health architecture, and it must be considered when other critical global policies has been developed, discussed around health emergency planning, universal health coverage, one health policy, and at the level of the primary health care. Ladies and gentlemen, I would like to conclude by saying we need not to wait for the right opportunity, but we need to create it, as mentioned by George Shaw. Ladies
Dear participants, we hope that this presentation had reached you, and we would like to thank Professor Ahmed Al-Fahal for his amazing, concise presentation, covering indeed the probably a SWOT strengths, weaknesses, opportunities, and threats analysis, covering skin NTDs, while also touching upon the important research aspects As said previously, he was not able to join us, but we would like to thank him for preparing this very effortful presentation and sharing with us this wealth of information. Therefore, this concludes part of the first panelist, and we'll directly move on to our questions from our panelists who are present here. And we can start by the first question, which is, what are the most common NTDs affecting vulnerable populations globally or in your region? And what are the primary challenges in combating them? We can start with Dr. Shelja.
Yeah, thank you, Ibrahim. First of all, thank you so much for that wonderful presentation. Coming to your question, so when we talk about NTDs, as you correctly pointed out, it has to be talked about in regions, because as we all know that it is already one region is specified for these diseases. So the region that I belong to is India, and so that is roughly true for all of South Asia. But having said that, let us please understand, depending on the kind of geography, whether this is an urban setting or rural setting, these stats might differ. Coming to the top three, I would say soil transmitted helminthic infections are the most notorious ones that we have in terms of the burden of disease. Then we have a huge burden of lymphatic filariasis, leishmaniasis, and dengue fever. These 3-4 diseases would definitely take the cake. But these might differ a little bit when we talk about incidence. So when we talk about morbidity causing illnesses, the helminthic infections and nematodic infections, they take the cake. But when we talk about deaths, then rabies definitely moves up the ladder, which leishmaniasis definitely moves up the ladder, and definitely dengue. So that is about India. Coming to the challenges that are there in India or in our region, I would say that they are very similar to the global perspective of NTDs, whether we talk about lack in research, which Dr. Fahal has also pointed out in his presentation. So definitely the research in terms of diagnostics, the preventive therapies that we need is underfunded, and it is not, so to speak, it is not really the hot topic for many researchers and young researchers. So lack of research is one. Then second, lack of I would have said lack of political commitment, but in the recent or at least past decade, we have been able to consolidate some of the efforts, at least in India. And I'm happy to come to like individual diseases if we talk about them, about what the government of India's efforts have been. But just so to tell you that not all the 20 diseases are there in India, but for most that are there, we have something or the other. So for each disease, we are in a different phase. There are some diseases where we are eliminating them. But yes, depending on which disease we are talking about, the challenges are always there. So the disease that we are about to eliminate, for example, filariasis, the challenge essentially lies in the last mile approach, which is that, okay, you've reached a certain level, but how do you now go from 95 to 100? Like, how do you have no cases at all? So that is what, how do you reach those communities that are already marginalized? You know that these diseases are the face of those communities. And when we talk about other diseases, we are lacking in diagnostics, and access to healthcare definitely remains a big problem. So that is just a summary. I'm happy to discuss about any detail in any of the diseases.
Hey, thank you so much, Dr. Shelja, for your inputs. I'm very sure that you did cover the fact that NTDs are distributed and they're mainly differ between rural and urban regions, and they also do differ from global regions. And also you did mention that there is the vulnerability still remains shared despite having different NTDs throughout the globe. We still find that the challenges are common, be it lack of research, be it problems with relations to diagnostics, and so on. I would like to thank you so much for your input. And moving on and passing on the exact same question, Dr. Rayan, would you like to give your thoughts on this?
Yeah, as Dr. Shalia said, we have a lot of things in common. I would say about Sudan, mainly we have leishmaniasis, schistosomiasis, mycetoma, soil transmitted helminthes, and leprosy. These are the main health problems that the research, coming from my research background, is focusing on. We have some, as he also mentioned, there are different levels of addressing these diseases. I think leishmaniasis, mycetoma, are having much funding when compared to other NTDs. In our center, Masatoma Research Center, we are focusing on also addressing the biological aspects, genetic susceptibility to the disease, the pathogens themselves. So these are the main diseases, NTDs in Sudan. I would say also the challenges is the funding. For the tropical diseases, 2/3 of the funding is going to HIV, malaria, and TB. NTDs are getting a very small share of this. So this is a primary challenge. Also, the centralization of the healthcare centers. So coming also from the mastoma background, so we have the Mastoma Research Center in the capital Khartoum, but most of the endemic areas are in other states like Al Jazeera, Sinnar, and White Nile. Now we're addressing this issue by making some centers in there also. We have a center in Sinnar State in the eastern locality. So yeah, these are the main issues regarding Sudan.
Okay, thank you so much, Dr. Rayan. You did cover the fact that funding is really a big issue when it comes to neglected tropical diseases, particularly because the big three of the CDs, basically HIV, TB, and malaria, really do get most of that. And you also did mention some of the prevalent NTDs in Sudan, including leishmaniasis and mycetoma, of course. I really like the point where you did mention that we're trying to reach out to vulnerable communities by increasing the proximity of the centers to those who need them most. And I think this is a very interesting sort of key point I could probably extract from what you have just added. So thank you so much for your input. And we'd like to have Dr. Letitia to give us her insights on the same question.
Hi, all. Can you hear me? Okay, so thank you for having me here. I would like to say that the same points the other doctors made about it are very prevalent in Brazil as well, but some diseases are different. And we have, for an example, Chagas disease, which is endemic to Latin America. So I would like to focus on Chagas because one of the main challenges we have with Chagas is building affordable housing in the countryside. One of the main forms of transmission of this disease is by the triatomine bug that lives in wattle and dabo houses that are built by the workers when they are pushed to the outside of the urban areas, or by the expansion of the agro industry, where they have to move further away in the countryside to the wild areas where the natural cycle of the bug happens. And then they have to build these houses with the materials they have in hand. So building of affordable houses with good hygiene conditions, it's one of the main challenges of controlling the disease. And also it has been a rise in transmission through food contaminated by the bug or the trypanosoma, and access to clean methods of processing the food is fundamental to curb the disease. But we have seen that lately, especially in the last government we had, the investments in public measures for either the food processing or the affordable housing have been sinking a lot. We have very low investment in those areas. And as the other doctors mentioned, we have some diseases that get more investment, like dengue has had more investment lately with the campaigns against the mosquito, but some diseases like Chagas are being more neglected, even more neglected as the other tropical diseases. And I think one of the main challenges we have is more on the social aspect, since we already have the means to diagnose and to treat the disease, but we're not connecting the people affected to those technologies.
Okay, thank you so much, Dr. Letitia. I just would like to thank you very much for your inputs on this answer. it's very true that NTDs did get a bit of decreased attention. And particularly, I can also kind of reflect on 2 points, one of which is sort of the NTDs not getting that spotlight post-COVID, and maybe the lack of commitment towards neglected tropical diseases, and also the aspect of the spread of dengue fever. I guess maybe Dr. Rayyan can cover that more from our side here in Sudan. We do have a similar issue which has popped up. So I thank you all for your answers, and I'll pass on to Janil.
Thank you, everyone, for your amazing inputs. Coming to the second question, and this is a really interesting one, seeing as we just talked, I think all three of you mentioned that funding from the government and commitment from the government is a real issue within neglected tropical diseases. So usually I know for a fact that in my country, that is India, community engagement, building community engagement to fight NTDs is a very prevalent thing. And I'm sure that in all countries, in all tropical countries, that is something that should be done, since, like we said, financing from the government is always a tricky situation. So I'd like to put forward the next question, that is, how can community engagement and participation be promoted in neglected tropical disease control programs? And what strategies can be employed to build trust and promote ownership among affected communities? I'd like to start with Dr. Rayyan.
So I would say that communicating with stakeholders and community leaders in the early stages of the intervention or establishing these programs is a must. So we should work with the communities and not for the communities. I can reflect also on some of our experiences, but this time I'll talk about another NTD, which is podoconiosis. It's a lymphedema that is highly endemic in Ethiopia. It's generated through long-term contact with volcanic clay. So the main intervention would be for the people who are living in the affected communities to wear shoes. And when they were offered these shoes, they refused to use it because they're not used to it. So now the current interventions being made regarding this NTD is involving stakeholders, community leaders, as well as the affected communities in any intervention regarding this. So yeah, we have a similar experience in mycetoma. So also one of the main problems is that the transmission of the disease is usually through a thorn break. And we suspect that the causative agents are found in the animal lungs. So in the one of the endemic villages, we tried to remove the animals from the houses into cages outside the village. But this did not work because the villagers are actually used to having their animals within their houses to be more safe. So it was a big failure, but now we're getting more into community engagement and actually involving the villagers in what possible ways that can be used to do similar interventions. So yeah.
Thank you so much for your input. I really loved how you highlighted that it's really important to build trust within communities, because otherwise the solutions which are offered from a scientific perspective may not be employed because of customs and traditions. Now I'd like to ask the same question to Dr. Spangler and listen to what inputs she has.
So Brazil has had many successful campaigns regarding dengue fever, for an example, that consists on health education. And I think those campaigns could be maintained. We had a bit of a setback with investments on those public health campaigns with the last government, but we're picking up pace again. And I think that those campaigns are a staple of Brazilian health, that we can maintain these campaigns, and people usually trust the healthcare systems that go to the houses and evaluate the environment and give tips on how to keep the mosquito at bay in the case of dengue. but we need more engagement of the population in the decisions made that affect the healthcare. We have the Municipal Council of Health, where people can take part on these meetings and then decide the plan for the next year for the investment of that city or that town where they're going to invest their money for healthcare policies. And this year we're having all across Brazil the municipal council, and then people can take part on that, and through that build the decisions for the investments for the next years. So I think we should have a campaign that focus on making people aware that they can have a role on the decision. The public health campaigns, we are taking care of that and they're working, but we need more investments toward making the politics and making the decisions regarding their own health through the public pathway. I think that's where we need to focus our campaigns on, so that the public can have the autonomy to decide where they need the investments.
Absolutely. Thank you so much for your inputs. Summarizing that, I really love how you highlighted that community engagement can come at a lot of levels, including political decision making. And it's really important to involve the community in that aspect as well, because ultimately it is the decisions that are being made for them, and that should respect them and should reflect the kind of healthcare that they need. And finally, I'd like to direct this question to Dr. Shelja to have her inputs on what the situation is in India.
So this was a really interesting question, and I realized that in Government of India, there is no one program that is, addressing all the entities together, but they are addressed under various umbrellas. So I'll pick out the most successful models that we have here, and I would like to share that maybe that benefits everybody. So the first one that we have a solid model about community engagement is the flagship program of Ministry of Health over here, which is called the National Health Mission. In National Health Mission, we have, and I'm very sure that other countries might have something similar, we have somebody called accredited social health activist, or ASHAs as we call them, which are basically community members who have been selected to work on a part-time basis with the government or with the health department of that particular state, which are basically the administrative blocks that we have over here. So these people, they are women most likely, almost always. So these women, they are from that same community, they understand that community, and they understand the people over there, and they understand their hardship. And that is why this model works. Now, where do entities fit in over here? This model works very aggressively, or I would say it puts a lot of emphasis on something called WASH practices, the water, sanitation, and hygiene practices. And we know that water, sanitation, and hygiene is something that is very important to address entities altogether. So I would say that the Government of India in one way or the other is addressing entities, but yes, that model is a very powerful tool of community engagement, because how do they actually leverage this trust that these community workers already have with the healthcare system is that they organize something called a village health, sanitation, and nutrition day, which is something similar to, I think, what Dr. Spangler was talking about when she's talked about a health council, or maybe it is a different concept. Basically, the idea is to get the front line or the community health workers, your local your local leadership together, and some of the community members, so that they can sit down and they can plan that, these are the problems related to sanitation, these are the problems related to hygiene, and this is how we are supposed to go forward. So sometimes there'll be targets that will be given by the government, and sometimes the communities will decide themselves that, we've received this fund from the government, and let us try to now use it for sanitation, hygiene, and nutrition per se. Second important model is that so all the 4 diseases, 4 vector-borne diseases that we have in entities, your lymphatic filariasis, leishmaniasis, dengue, and I think one more I'm forgetting. Anyways, so we have something called integrated vector management, and integrated vector management as a strategy is proposed by WHO also to, combat entities, because all of these have a very complex dynamic relationship with each other, and you target one, then you will be able to manage all of them. So in IEC, so this particular program, this is a very big program. It has vertical integration. It utilizes these frontline workers, and it utilizes that bond that is already there between the community and these community health workers to do IEC. Now, this is not a simple IEC process wherein a medical officer who hardly steps out in the community is going to the community and telling them that you should clean out your coolers and you should throw away the water so not to let the mosquitoes breed. These are the people who will be sitting with them, who will be taking them to the hospital if the need be. So the effect like that is more. So I think these are two solid models that Government of India already has and are working. The third one might sound a little tone deaf in the light of this kind of engagement, but it really works, and that is money. So when you give incentives and benefits to patients to come and take the treatment, it really actually breaks that access barrier. So that kind of thing we have for two programs over here. We know that morbidity is it's very high in leprosy and also in leishmaniasis. So for both of these programs, and because they are associated with stigma also, so the Government of India realizes that, simply telling the patients that you should not be afraid of it and you should not feel stigmatized does not work. So there are cash incentives that are given to the patients to actually continue the treatment. So I think these three examples are the most successful examples that we have here for community engagement.
Thank you so much. I really appreciate how you summarized three very different programs, including community engagement by direct participation from the community, like you said, cash from the community, and overall summarizing all three answers. I feel like we got a lot of different perspectives. Like Dr. Ryan highlighted that some things might not be adopted due to customs. Dr. Spangler said that it's really important to involve the community in their decision-making, in the political decision-making as well. And Dr. Shelja highlighted how involving the community directly, like workers from the community helping to disseminate healthcare and awareness also helps. So wonderful inputs, everyone. I'd like to hand the floor back to Ibrahim for the next question.
Okay, moving on to our next question. We really do know that at this time, neglected tropical diseases face a very huge issue when it comes to sustainable medications and suitable medications for these diseases. And we've seen many initiatives pop up, such as drugs for neglected diseases initiatives, among others, just to try and fill that gap which NTDs have acquired due to their neglected status with regards to effective and affordable treatments. So the question that I would like to pass on to you guys is, what are some of the key challenges in ensuring access to affordable and effective treatments for neglected tropical diseases? We can start off with Dr. Spangler.
Hi, so I think one of the main challenges, especially in the countryside of Brazil, is that we, like India, we have a very vast territory, and some of the measures in public health don't reach all the territory. And unfortunately, some of the tropical diseases are more prevalent in those remote areas. So for people to have access to healthcare coming from those remote areas is a main challenge. For the centers that deal with the diseases are located in capital cities and very far away from where people are actually getting infected by those diseases. So when they have the process of getting infected and then getting diagnosed and then starting treatment, it takes a very long time. And for some diseases, we need to act fast. So for these people to have the diagnosis and the access to the first care, the primary care, to get the diagnosis and then to be transferred to a center for treatment, it can take a long while. So I think the time from infection to treatment is one of the main challenges we have here. And also the access to direct healthcare from people that live very far away in the countryside is one challenge. The other challenge is research into new medications, because we've had, like with Chagas disease that I already mentioned, we have two main medications that we use that have a very, very high incidence of side effects that cannot be used safely in pregnancy. So it kind of helps increase the congenital transmission. So we need more research into medications that are safe to use in pregnancy, for example, or medications that are more easy to use with less side effects. And we've had in the past government, it kind of froze all the investment in healthcare and education for at least 20 years. So that's, I think, our main challenge of the moment is with the public investment in research and in education and public investment in programs of outreach in healthcare for people that don't live close to the centers and don't live close to primary care in a way that they can have this fast access to medical care.
Okay, thank you so much for your insights, Dr. Spangler. I'm quite sure you did cover the aspects related to research, investment, and education as being factors that have hindered the accessible and affordable treatments for NTDs, especially for those living in remote areas where the burden may be twofold or double that of simply attaining the medications for neglected diseases. Okay, we can pass on to Dr. Shelja.
Yeah, so I think again the issues remain the same, but I would like to just draw your attention to other side of the things. So she talked about the issues that we face for therapeutic treatment, right? The drugs, they are very notorious. They in themselves have a lot of side effects. So the compliance is low. So something similar we face here while introducing the mass drug campaigns. So for, as I stated before, the top priority disease for us is NTD, the soil transmitted helminthic infections, and among them also filariasis. So what we do is basically mass drug administration into the community. We determine the transmission level, and then to all the people we give 3 drugs. So one is ivermectin, the second one is DEC or diethylcarbamazine, and the third one is albendazole. Now the problem is getting a community full of healthy people eat or take these 3 drugs. So that in itself poses a lot of challenge. And similarly for biannual deworming also, giving drug to a sick person is still acceptable because that person is in need of that drug. But giving these drugs all together to completely healthy, fit children, it poses a big challenge in itself. So I think we need some innovations over there. We definitely need research into more therapeutics and more preventive medications. Second, she's already talked about the health systems per se. Let me just call it health systems, whether we are talking about lack of infrastructure or we are talking about lack of diagnostic tests and all of these things. So as long as you do not have a test, you cannot really start them on treatment, whether or not it is affordable or not, whether or not it is acceptable, accessible or not. So the clinical suspicion of these diseases for clinicians still remain very low. I don't know how that is for other countries, but here still, because the symptoms are so vague. For example, for parasitic diseases also, and if you talk about vector-borne diseases also, the clinical suspicion remains low, and the health-seeking behavior of the people also remains very poor. So because these diseases generally cause more morbidity than mortality, like they will not cause death, but they will keep causing symptoms which the patients will try to manage them themselves. So the problem there remains a poor health-seeking behavior compounded on by a health system that is already failing in reaching them and in educating them. Then I think stigma and discrimination still remains a big problem with those diseases which are causing deformities, visible deformities like leprosy. So that it basically acts as intersectionality. All of these things, they keep compounding on each other. And on the top of that sits a lack of a clear guideline or a clear policy from the government side, committing to end these entities. So that would be my answer. I think those are the challenges.
Okay, thank you so much, Dr. Shelja, for your inputs. I think other than echoing what Dr. Spangler said about health system approaches, did cover the aspect of compliance and how NTD's treatments may be difficult to comply to due to their side effects, among others. And you also did mention the importance of research in helping us to discover and create new treatments for neglected tropical diseases. So thank you so much. And right now I'd like to hear from Dr. Rayan.
Yeah, so I completely agree with both previous doctors. We're having the same issues here in Sudan. I'll just add 2 more points. So for finding new drugs or new treatments, so the drug discovery is a very expensive, long journey. So most of the major pharmaceutical companies that usually are willing to invest. They are not interested in NTDs because there's no profit coming from these drugs. So this is one of the main issues. Another thing coming from my research background again is the lacking of understanding of the basic biological, basic biology of the pathogens and the host pathogen interactions, which makes it more harder to find molecular drug targets to target these NTDs. So otherwise the same problems we face and the same as the previously mentioned issues.
Okay, thank you so much, Dr. Rayan. So you did cover a new perspective about how NTDs could also be a challenge for pharmaceutical companies due to them being a huge investment. And on top of that, the lack of understanding of the biology and pathophysiology of these infectious agents that do cause NTDs. I'd like also to take a step back to something which Dr. Shelja said, that the health-seeking behavior of community members. And I think that's also a very critical issue when it comes to treatment, because treatment is about discovering the disease early enough and avoiding further complications. And I think that health-seeking behavior is a very important point that you did highlight there, and the fact that the higher morbidity than mortality of NTDs makes them a very tricky sort of subject to navigate when it comes to health-seeking behavior. So thank you all, and I'll be passing on to Janelle.
Moving on to the next question, and so this is a really important question because here within these organizations, we really believe in meaningful youth engagement and engagement of students in these things. So we would like to ask the panelists, what factors contribute to the persistence of neglected tropical diseases in certain regions? And most importantly, how can we as medical students work to address underlying social determinants of health that drive these disparities? What could be our role, and how could we do better in that aspect? I'd like to first pose this question to Dr. Rayan Ali.
Yeah, so I would say that students are valuable players, first to promote the scientific research on NTDs. So we are the countries affected by NTDs, so we should be the key players in combating them. Students can help in campaigns in raising awareness about the importance of combating NTDs. So I think these are the main answers for this question.
Thank you so much. I really love how you highlighted the research aspect of it, because as future healthcare providers, that is something that we can really work on. I'd now like to forward this question to Dr. Shelja.
Yeah, hi. I would also like to start with research only because, as you pointed out, that is definitely where we can talk about youth engagement in the most realistic sense. So just a few things about research. Let us also invest. One of the major reasons I believe we always talk about diagnostics and therapeutic research, right? We always talk about innovation, how there should be more medicines, there should be better medicines. But also there is a body of research that is something called implementation research, which talks about the interventions that we already have and why do they work and why do they not. So I believe implementational research in the field of NTDs regarding the interventions that are already there, we need to work on that. So WHO has also shifted from process to impact. They say we will not look at what you have invested in, we will look at what you have been able to change. So similarly, if I due credit to diagnostics and therapeutics, and definitely research should go on there, but more realistically speaking, for youth and for students, maybe looking into implementational research for the kind of interventions that the government is putting into place already, why they are working and why they are not working. Because let us understand that these diseases sometimes can be very contextual, they can be associated with social and cultural practices, and the whole pathogenesis of these diseases in community. So the whole web of causation in community is not something that can be tackled by health sector alone. And that is also a persisting problem. That is also why we still have a huge burden of entities, because we need all the sectors to come together. We need all the fields of medicine to come together to actually tackle these issues. Just a very small example to explain that: when it comes to snake bites, right? Snake bites is a disease that has been added recently. Now snake bites are very common in particular communities only. So you might have a sporadic case of snake bite here and there in urban communities, but when you go to rural communities, especially in India, there are communities whose profession is to catch snakes. You know, you have snake charmers, and there might be communities who actually worship these snakes. So it's not easy bringing about a change in these people in these communities without actually upsetting them. So what is the answer? The answer is implementation research. Do not go ahead and look only at the newer diagnostics, but also at what is in your hand. So one thing, I think one key home message could be that maybe all of the students can go back and look into qualitative research methods. That is the science of understanding the stories or understanding the depth of issues, and that is something that you can actually do. Because again, coming back, why are entities persisting is because we do not have data. If you do not have data on the burden, if you do not have data on how the problem is actually persisting in the community and spreading further, you will not be able to convince anybody to give you money. If you are not able to, convince them that this is a problem. And a very good way to actually bring about change for youth, and this goes in general for everybody, is to actually highlight the problem or actually describe the problem for your policymakers. If you describe the problem well, you will be able to give them hope for an effective solution. So that is one. And then definitely we can talk about other factors like climate change. Again, this is all very socio-political. So entities is something that is not the responsibility of health sector. Urban development comes into picture. Those disparities between healthcare of the urban poor and the urban rich, those disparities come into picture. Then climate change comes into picture, because climate change, we know, changes the breeding habit of vectors. And then you have another whole issue of drug resistance. So these are the things that we can talk about always, but I think the realistic way to go about youth engagement would be to expand your horizon of research, not only on the quantitative aspect, but actually the qualitative aspects also. Why do people go to a certain place to seek treatment? Why do they not go for a particular disease? Those kind of questions we need to answer.
Thank you so much, ma'am. I really love how you highlighted that, yes, research, but building upon that, it does not just need to be the more clinical side of things, but a very wide spectrum of different kinds of things that can be incorporated within research, such as why people are taking up some medicines, why there is non-compliance, and a lot of other things as well. And another really important point that we appreciate was the intersectoral collaboration that you highlighted, that there should be collaboration between different sectors that all contribute to health, especially within neglected tropical diseases, especially within areas which are more vulnerable to it. So thank you so much for your inputs. And now I'd like to pose the same question to Dr. Spangler and add another element to it, that as well as the factors that are already present in the community which are contributing to the persistence of NTDs, as well as that there's a lot of new technology coming in, there's a lot of new interventions coming in. So in both of these aspects, how can medical students drive the change to be a better aid to reducing the impact of NTDs overall?
So it was very well said regarding research. I think that's one of the main forms of engagement that the students can have to combat the diseases. But I'd like to highlight more a political side of it, like I mentioned, with the community, that they can take part in the political decisions. So the same goes for the medical students. On those councils that I mentioned, there are seats for students, as well as seats for community leaders and seats for politicians. So I think it's important for the students to occupy those spaces and to voice their concerns and to be a voice for the community regarding those issues. Also, community engagement by the students with projects on the universities that reach to the community and do some health education regarding those diseases, or do some health promotion, or organizing days for a health assessment that could lead to discovering a disease that is there but is silent, and to help prevent the further of this disease. So organizing healthcare reach days or taking part in community education programs, or even the political matter, as said, I think are very important aspects of the student participation outside of the scope of academic research.
Thank you so much for your inputs. I love how you again highlighted community engagement in different ways, as well as advocacy efforts that can be undertaken by medical students to give a very holistic approach to entities and ways we can contribute to them. I'd like to hand over back to Ibrahim.
Okay, thank you so much, Janelle. Now that we have concluded the questions that we have for our panelists, we will be taking one question which we received from our participants. This question asks, what are the most probable causes that obstacle communities to eliminate NTDs? So who would like to take this question?
Yes,
Okay,
Dr.
I guess I'll go first. So that's a loaded question because again, we need to think about which kind of entities we are talking about. But I think as a blanket statement, it's safe to say the lack of awareness is the first and foremost. As we've already talked about, if we talk about the most common entities, which are the soil transmitted helminthic infections or your vector-borne diseases, the sheer lack of awareness of how our own actions are actually leading to these diseases, that is the most common challenge. That is the most problem over here.
Okay, thank you so much. Dr. Rayan, would you like to add?
Yeah, I would totally agree. So yeah, lack of awareness, and also not engaging these affected communities in any interventions. So yeah, it is a complicated question that have a lot of aspects.
Okay, thank you so much, Dr. Spangler.
I think it's very well said. The lack of awareness is one of the major challenges, and also how the community approaches the disease and the shame in having the disease. So people don't reach out to healthcare because they're ashamed, or like we all said, the lack of public investments and the lack of campaigns to target those populations. So it's really depending, like Dr. Shailesh said, it's really depending on which disease we're talking about. But as an umbrella of all the diseases, I think those are the main challenges.
Okay, thank you so much, Dr. Spangler. And with that, I guess we have exhausted the time allocated for this webinar. I would like firstly to thank all the panelists for taking out a lot of their time to make it here and to share your very great insights with us, a group of medical students from around the world. And I would also like to thank our participants who came forward today and took out also part of their time on this Sunday to see and learn more about neglected tropical diseases and how their issues prevail in different areas around the world. And with that, I would like to pass on to Janelle, and we can also conclude with the screening and take a picture with all the participants.
Yeah, just working on